This is the first half hour will be a discussion, and I'll be monitoring the chat. But if you would like to actually speak to us, raise your hand, and Sarah and I will try to unmute you so that you can do so. None of us was happy with the rollout of psychedelic assisted therapy, the lack of consultation, the lack of guidance documents, and now there's the FDA refusal of MDA, which further complicates the issue. But the science base, both in terms of efficacy and effectiveness, is robust. However, our colleague in Zurich, Robin van Rotz, has pointed out, and I quote, "Pharmacological effects cannot be completely separated from our expectations, attitudes, and perspectives." Australia is not the only country doing this. Switzerland has been doing it since the 1980s, and there's a robust science effort, particularly in Boston with Mass General Hospital and Harvard University. So we work closely with those people and try to develop our own guidelines since none were forthcoming. I'm just going to briefly highlight a few of the decisions we made in Townsville. One, we said that any application would be considered as phase 4 research as well as therapy, because there's a lot that needs to be learned from this process, and because putting it into the research realm indemnifies our committee. We also decided that we wanted to see quarterly reports, and our coordinator, Kelly Parker, drafted a guidance document, which we found quite functional. We've only approved one provider, and we approved that provider in November, but they didn't get up and running until May because they're in New South Wales, and the state requirements that were overlaid on top of TGA requirements were so onerous it took them that long to do it. So that's our experience, but I'm going to immediately now turn it over to Paul Gatenby, who really has the whole scene covered.
I just want to make some brief points. Psychiatrists can be authorised under what's called the TGA Authorised Prescriber Scheme to prescribe either MDMA for post-traumatic stress disorder or psilocybin for treatment-resistant depression. And there are a whole lot of additional factors that have to be taken into account with this practice. And this is not a unique scheme. This is a scheme that has been around for quite a while, and to my mind has very little to do with research. What we're being asked to do, and basically it's a scheme that involves HRECs. It's been imposed by the TGA. We've been shanghaied into doing this essentially. The HRECs require NH and MRC certification to give a degree of respectability to us, which means that we're the only one in the ACT that can do this, because none of the others have NH and MRC accreditation. It's not research, it's clinical care. Now, overall, the members of my ethics committee don't want to do this. We don't want to do it for this drug. We don't want to do it for any of the drugs we're asked to do it for, drugs and devices. This particular set of drugs, these two drugs, have come to make up about half our applications under this scheme in the period in which they've been licensed. But I've taken the view that if we agree to help the TGA in this way, and the agreement was long before I was the chairman. In fact, prior to being chairman, I was director of research, and it was long before that. So we're going back to the early 2000s at least. Originally, the scheme was set up to give the TGA some parochial local knowledge, because they thought all these applications under the authorised prescriber scheme come for drugs that are largely used in teaching hospitals. And the ethics committees in those hospitals will know who's a rat bag and we shouldn't give a licence to. Now, they've come to realise that, of course, that's no longer true. The NMA assessment basically means that anyone from anywhere can apply to any ethics committee to get their research approved, and they've applied to any ethics committee to get their authorised prescriber scheme approved as well. And so this idea of us providing parochial guidance is now a nonsense. So this concerns us too, and it obviously concerns the TGA because they've added a medical advisor into their process. my own view is that the TGA should set up their own scheme of experts to advise them in this. I don't believe the Ethics Committee should pick and choose what devices or drugs they agree to assess under this scheme. If we say we're going to participate in the authorised prescriber scheme, I think it would be a dangerous precedent to say, but we won't do it for the psychedelics, but we'll continue to do it for, devices, hips that haven't got hip replacements that aren't fully licensed, for example, something like that. So I think that this is important that we have a degree of consistency. This is overall what we've licensed to date. This is on a background of 28 total applications under this scheme for the period, 10 for MDMA, 5 for psilocybin, 15 altogether, broken down there. So you can see that we probably have licensed most of the authorised prescribers in Australia. This is where they've come from. None from the Northern Territory, none from Tasmania, very few from Victoria, few from South Australia. They've come from, not South Australia. How do I get rid of this so I can read my own slide? That'd be Queensland. So New South Wales, South Australia and WA and the ACT are where most of our applicants have come from. This gives us some idea of the success. Most of the applicants are ultimately successful. I thought for a while that the quality of applications were going off, but in fact that wasn't true. It's the result of a meeting that I was absent. And then when I looked at the meeting, I saw that really the applications weren't much different than the ones we'd had before. The applicants take it seriously. We never get an application that we don't seek clarification or minor changes, and I'll talk a bit about the changes in a minute. But I mean, the applicants largely, well, completely really meet all the guidelines that the TGA have produced to do this. Now, we may say, well, the evidence that these drugs actually work is not particularly good, but I mean, the TGA have been given expert advice by presumably the usual method is a panel they've created to examine the facts around these two drugs and the two conditions they're licensed for and the constraints around the treatment, and they've agreed to license them. We hear rumours about political pressure, but nothing happens in Canberra without political pressure. These are the common feedback themes. It's a very busy slide. People must be used to that at this meeting by now. I'm going to consolidate some of these together and just talk about the issues that we raise most often with the applicants. The applicants tend to underplay the drug safety side effect issues, and we seek clarification about that. We're very concerned about coercion and consent. I mean, understandably, most of the patients who are going to receive these medications under this scheme are already patients of the psychiatrist who is going to prescribe them. And this does raise the issue of coercion, and both by the potential patient, they're not subjects, they're just getting clinical treatment, and the prescribing psychiatrist in both directions. We like to see them try and tell us in some detail what they do to try and ensure that that doesn't happen. Cooling off periods, involvement of other healthcare providers, involvement of a support person, this sort of thing. When they actually come to have therapy, there has to be two therapists, one the psychiatrist and the other one usually a psychologist. And all of those people have to be named. And we insist, with one exception, which is Aboriginal support people, we insist on everyone being professionally registered with APRA so they can be got at if they do naughty things. We have had applications where people have got their friendly chemist, and I don't mean pharmacist, into the mix, and that's unacceptable because that's how footballers get drugs. Drug handling and security is often overlooked. People seem to forget when they put in this application that these things are street drugs, potentially, and so they need to have security that will prevent that happening. It would kill the scheme if it became a major source of supply, the street supply for these two groups of medications. And then supervision. The Royal College of Psychiatrists, Australia and New Zealand, demanded supervision, and the TGA have agreed with that. And the supervision has to be of people who've had experience. And there are enough people in Australia who've had experience through research studies or work overseas. And the community of those applying to use these drugs seem to have built up a supervisory network which subject to some clarification with each of them, appears to work all right. So that's really all I have to say for the moment. And just to summarise, I see this as approving clinical care. I don't see it as approving research, but like the folks in Townsville, we do insist on monitoring and regular reports. We copied that from them, and we're aware of a nationwide attempt to collect the data coming from my own university, from ANU, and we insist that the people actually agree to submit data there. I think the TGA ought to have been running a scheme like that, but they didn't respond positively to our suggestions. But I'm happy to consider the broader concept of these drugs, and happy to listen to other people's views about how we could argue about which ones we ought to, which drugs and devices we should give approval to when we've agreed to be part of the scheme. So thanks very much for the moment.
I'm going to interject just before we go on to Ian to highlight the fact that informed consent in this scenario is particularly problematic because of the nature of the experience, the mind-altering experience, and the individual nature of all of that. What does informed consent consist of? And there's a robust literature on this, but there's no clear path. Ian, over to you.
I agree, Hudson, and I think we down in Adelaide, we do a lot of authorised prescriber, but I think the problem is this is a really weird scheme, as Paul says, for the TGA. It's not only a drug, it's a psychiatric component, and that's never been done before as a dual thing, as either it's a device or a malaria drug or whatever. It's never a twin thing. So you've not only got the drug, it's the psychiatry that goes with it, and I think that's been the difficult sticking point, is the psychiatry that goes with it. Now, we've had issues that there's no psychiatrist in Adelaide who's going to spend 10 hours with a patient. So that's been the problem. And there's been efforts to downgrade that to a psychologist or some other mental health worker. And I think the TGA is pushing back at that. But that's one of the sticking points, is the heavy psychiatric involvement. And in some places that's a non-starter, or the cost is prohibitive. So I think there's a few little foibles, but I do agree with Paul. I was really amazed that this came under authorised prescriber. Now, whether there's any pressure from anybody to get this moving, as Paul says, who knows? But it's certainly a weird thing to be in the authorised prescriber space. And informed consent, I mean, you could ask yourself, how could there ever be informed consent in this process from a patient? It's almost like it's coercion, but yeah, I agree. Certainly problematic.
I have a colleague who's also a friend who's also a psychiatrist, and I had heard through channels that he was dead set against this program. And so I got together with him and asked him about it. And I said, I hear you're against it. And he said, yes, I am. And I said, Why? And he said, Hudson, I've been a psychiatrist for nearly 40 years. I've been taking mushroom trips for a lot longer than that. And I can't think of anything worse than doing a mushroom trip with an expletive deleted psychiatrist sitting next to you the whole time.
Yeah.
Angela Diedrichs has a hand up. Can we get his voice so we can hear from him? Looks like you're unmuted, Angelo. Speak.
Thanks, Hudson. As a psychiatrist and a chair of an ethics committee, we found this quite challenging to contemplate when it came up. As a psychiatrist, I was already quite aware of the discussions and the proposals that were underway. My primary concern, I think, for me, there's two issues. The one is the whole question of the authorized prescriber scheme as a whole and the role of HRECs in that. And that's been an issue for a much longer time than just these medications. But then in the more recent time with this issue, the College of Psychiatry actually made 2 submissions to the TGA in the lead up to this. And in both of their submissions, they actually advised against this plan. The TGA went ahead and applied the authorized prescriber scheme despite the college's recommendations. After the scheme was then approved, the college then developed a memorandum of clinical and therapeutic guidelines for people who were going to use these agents. And I think that, for me, colors the picture somewhat. The other thing for me that was quite an issue as the chair of the local HREC is I am familiar, obviously, with all of the psychiatrists in town. And I perceived myself as having a significant conflict of interest in being able to make any determination that would be entirely objective. When I put this to my committee, they said, no, we agree. We think you do have a conflict of interest. And the committee actually had a discussion without me present. It was chaired by the deputy chair of the committee with input from the director of research. And the committee decided that they actually wanted nothing to do with the process. Because they wouldn't have psychiatry expertise. And I think one of the other concerns for me is the reality that these medications are essentially approved for as an assistant or an aid to psychotherapy, which becomes then an integral part of what's actually happening in the protocol, what needs to be happening in the protocol. And that has significant time implications for participants and for the therapists involved. And the final point I wanted to just make was that the question around capacity to consent, in the ideal scenario, I would imagine that the consent would be obtained before the substances are being administered. And I would hope that at that point, the capacity would still be intact. Obviously, once the substance is administered, capacity will then be altered. And that may well then have an implication on how things proceed. But I thought I must just get that off my chest and throw my little bit into the picture, because for me, this was a very conflicting issue, not just because I have an issue with the authorized prescriber scheme as a whole and the requirements of HRECs, but in this particular one, because it's right in my clinical workspace.
Thank you. Any other comments? Anybody else want to? Speaking of how Switzerland's been doing this since the 80s, they now do it in groups. And they take the participants on a nature walk when the drug is at its maximum effect, and they find that all of the major breakthroughs come about when that happens. I'm not suggesting we'll ever go down that path, but it's quite a good contrast. Ian, back to you.
Yeah, so my comment would be, Hudson, and maybe here for Tom in a minute. I'm not sure how this could ever be a therapy going on long term, when there's so many issues with it. I just cannot see how this will ever be a therapy in clinical practice. It may be a niche therapy. I think that's its role. But I think everyone who wants to roll it out, and roll these drugs out in the general area of psychiatry, I think is mistaken. I can't see how these drugs will ever be used a lot in clinical practice. I think it will always be a niche therapy. I mean, you look at psilocybin, the psychiatrist has got to be there 10 hours or 8 hours or something for a session. That's never going to happen, right? I just think it's impractical. So these will be niche areas. And you're right. I think the the TGA is having its cake and eating it too with handing authorised prescriber this in the authorised prescriber scheme, because they're saying we don't want to approve these drugs in case we have legal action against us, but we'll pass it on to the HREC as having some local knowledge, so we'll have our cake and eat it too. We can blame them if something goes wrong, you see. That's what it's all about. TGA can say, oh, it was the HREC that approved it, not us, you know, so.
Yeah, can I just comment there? They do have
Yeah.
to sign off on it as well.
Sure, but they can say, oh, well, we took the advice of the HREC, Paul, you know?
Yes, our first approval, TGA approved within 2 weeks of receiving it.
Oh, the HREC's approved it, that's fine. So that's their get out, I think. That's why they gave it to HRECs. It's just the TGA would say, no, it's too hard for us to approve this. We're just not going to do that legally.
Regarding the dosage, one of the other unresolved questions is this a one-shot deal? Does one psychedelic experience cure someone of profound depression in a way that no other drug's been able to do?
Yes.
And the evidence base is still unclear about that, about the frequency that this would be needed. And the TGA requirement now is that a psychiatrist be present during the whole psychedelic trip, which means that a therapy session is $30,000, which means that this right now is only an option for somebody who's profoundly ill and also very rich.
And I also raised the question of long-term effects. Hudson and Paul, I sent you that article today, just been released, a Canadian study where schizophrenia rates in people who have these drugs are 3 times higher than the normal population, sometimes 7 times higher if unadjusted, which is really scary, I think. So maybe where it's like a thalidomide type of thing. Well, oh, actually, it looks good initially, and then, oh my God, it's a disaster. So just putting it out there.
That bears looking into, because the literature on schizophrenia and psychedelics has always been that psychedelics aren't causative or no evidence has cropped up, but there's lots of evidence that if one has a mental health condition or is on that pathway, the worst thing you can do is take psychedelic drugs. So this new study bears a lot of,
yes.
That was an Australian doctor, and the commentary by Professor Liu along with it.
Yes, it was just
reading.
Yes, New South Wales. It was just cut from a Canadian study, but that's really scary. You know, again, we have this problem where drugs look good initially, and then 5 or 10 years later, there's a disaster, right? Because the proper studies weren't done at the time. So, you know, who knows?
Yeah. Can I just comment on that? I mean, 2 things make me slightly hesitant to be that worried about it as that study is. I mean, that study that study, I believe, included people who acquired the drug as a street drug.
Sure.
So, you know, you already have evidence that they may not be the same as the population who's being treated here. They may have a priori reasons why they become schizophrenic. And the other thing is that, I mean, the Swiss experience does go back now to the 1980s, and they haven't reported this. I mean, they have a similar sort of mixture of psychotherapy and drug,
even so, Paul,
I don't know how they charge for it in Switzerland.
Yeah, but the numbers would still be low, Paul. I think one of the criticisms of these drugs is that the phase 3 trials haven't been done, so we don't know what the long-term effects of these things are. And even the Swiss, it'd be in the hundreds of people, that's all, I'm sure, even though it goes back to the 80s. I don't think the numbers are huge. So that's the problem. A couple of hundred is not a real guide to what's going to happen.
And when it comes down to trials, the main stumbling block there is it's impossible to do a double-blind trial. You can't blind people.
Sure.
Tim Leary and Richard Alpert did it in the 60s, and they gave the placebo group a placebo that was laced with nicotinic acid. So for the first half hour, half of the people said, oh, I can feel it, I'm on the trip. And then those effects wore off and the psilocybin kicked in. That was the Marsh Chapel experiment at Harvard, well worth reading about, or the Good Friday experiment.
I mean, I agree with you that the cost is prohibitive. And my impression was that it was being borne by work cover and insurance companies and things like that.
No insurance company yet covers it, although some of the major ones in the Defense Department are considering it. One of our concerns in Townsville is we've got a lot of a big military population, lots of PTSD, and if this works as the studies show it might, it would be beneficial, but it's not covered as yet. So yes, it's something that you have to pay for out of pocket right now.
It almost needs, Hudson, a psychiatrist to do this full time. I mean, I don't know how, if you've got to spend 8 hours with a patient, be a full-time job for a psychiatrist, you know.
And I don't know from our one approved therapist how they're doing that, but between May and now, they've processed 8 to 12 patients. So they're
Since May, one person. Is that what you're saying? Sorry. Because even that, just the burden on one clinician being there for 10 hours for 8 patients over what's only 6 months there, you can see why it's difficult. But I think like one way in which this may be able to become more than a niche therapy, I think when you look at that Swiss model and they are doing it in group settings, well, there's one way in which the cost could come down, but I think those studies need to be done. There are studies coming out of America within group settings, but again, the numbers are small. And I think, look, certainly that's my position as a researcher, is that although maybe the cat's out of the bag on some of these approvals, I think the science isn't quite there to say that these things are completely safe and that they are effective. But we'd like to see those sort of studies done, of course.
We're not going to know about long-term safety for a long, long time, though. All we're going to find out from the early safety studies is things like drug interactions that shouldn't have happened because someone's contraindicated antipsychotic drug wasn't stopped, and things like that. We're going to find out about them within the next couple of years. I mean,
so Paul, the FDA in August rejected MDMA. But from the Lycos trials, they were pretty stunning, really, the results they got. But what they're arguing is like 70% reduction or something amazing. But what they're arguing is, hey, we don't know what the long-term effects of these things are. So they accepted the brilliance of the original study, but hey, that's all very well. But what happens if this rolls out as a therapy? What's the long-term effect? So they rejected the application for MDMA. So everyone was there, what the hell? It's proven to be a stunning effect, 70%, I think, was the figure from memory. But the big question was, we're rejecting this because we don't know what the long-term effects are. So that's, I think, where we still are with all these drugs.
I think as well, some of the FDA's concerns there were around some potential ethical violations in those studies.
Sure. Yep.
And then the idea that if that is to be rolled out as a conventional therapy that's accessed by tens of thousands of people, well, what's the incidence rates of those sorts of ethical violations when we're in the community? And it suggests it's going to be more than in a clinical trial setting where we're under so much scrutiny. And that's something that really worries me.
But staggering effect, 70% no longer met the requirements for PTSD after the therapy. That's stunning, right? No therapy comes near that.
Psychedelics have come back into the research base now for a couple of decades, and the research has been promising. And we've got one comment: should HRECs embrace the process and let it run its course? And I think my committee has a higher tolerance for risk than others, and so we said yes. And we took a careful look at the study, at the science, and the science, when you look at it as a whole, up till now, does look promising for psilocybin, for depression and PTSD, for MDMA for PTSD is what I was trying to say. But what I really want to say now is, Tom, we've already heard from you